Real talk. Real topics. Real solutions. This is MSR Forefront with your host, Stephenetta Harmon.
We must slow the spread of COVID-19 to protect our communities. Right now, it is important to wash your hands often, get tested if you have symptoms, stay 6 feet away from other people, wear a mask when you go out, stay home when you can, and work from home when able. Thank you for doing your part. Stay safe, Minnesota.
Good evening. Welcome and thank you for tuning in to the latest installment of the MSR Forefront, where we are committed to authentic conversations with elected officials, organizations, and thought leaders on issues that are pertinent to Black communities in Minnesota and beyond. I am your host, Stephenetta Harmon, and tonight we're continuing our conversations from last week on the ongoing impact of COVID-19. But before we get started, I'd like to let you know that tonight's MSR Forefront is sponsored by Ramsey County Research. We must slow the spread of COVID-19 to protect our communities. So folks, stay vigilant during this time, wash your hands, wear a face mask, and stay 6 feet away from other people. Minnesota spokesman, recorder, and research by Ramsey County. Let's stay safe, Minnesota. And also, MSR Forefront is sponsored by the Minneapolis Foundation, Funds for Safe Communities. MSR is proud to be on the front lines with the Minneapolis Foundation to support efforts to prevent violence, address systemic inequities, and heal individuals and families. The MSR, the Minneapolis Foundation, and the citizens of the Twin Cities, let's find solutions together. Okay, so tonight we're talking COVID-19. As you can clearly see, we have the honor of not one, but 3 Black doctors this evening to share their thoughts on the conversations that we should be having in our communities and how we should be showing up and being represented. So I'd like to welcome Dr. Zeke McKinney, Dr. Busola Akinseti, and Dr. Nathan Chomolo. Let's see if we get them all on here real quick. And we're going to be talking, again, coronavirus, how the impact on Black communities. Hey, is everybody here?
Yes.
There we go. Yes. Hi, good evening. How are you all?
Well, thank you. How are you?
I'm well. Well, thank you so much for tuning in and joining in this conversation. I want to start off, with introducing the panel. We have Dr. McKinney. We got into the nitty-gritty with you last week about the pandemic. For the folks who weren't here last week, he's an occupational medicine specialist for Health Partners, affiliate assistant professor for the U of M School of Public Health, chief medical editor of Minnesota Medicine, and head of Health Partners COVID-19 vaccine trial studies. So, yes, thank you so much for joining us. We also have Dr. Akinseti. She's department chair of infectious disease for Health Partners Medical Group, assistant professor for Division of Infectious Disease for the University of Minnesota, and a member of the expert panel for treatment and research of COVID-19 infection for Health Partners Medical Group. And Dr. Chomolo, he's medical director for the state of Minnesota's Medicaid and Minnesota Care programs. He's also a general pediatrician and hospital internist with Park Nicollet, and he serves on the boards of the Minnesota chapter of the of the American Academy. I'm trying to put African in everything, right? The American Academy of Pediatrics and Reach Out and Read Minnesota, and an adjunct assistant professor of pediatrics at the U of M Medical School. So what I'm saying here is we have 3 credentialed story doctors with all the letters behind their names to really get into good conversation tonight. And so just welcome. And for those of you who are tuning in just now, please drop a comment or a question related to this conversation on where we are. So who would like to start first on just kind of giving a lay of the land on how they are seeing coronavirus impacting Black Minnesotans right now? What are you seeing on a day-to-day? Who? See, Dr. Akinseti, how you doing?
I'm good, thanks.
Just gonna wait for someone to raise their hand.
All right.
So what does your day-to-day look like right now with seeing in the community for Minnesotans in general, but particularly Black communities?
Yeah, well, I see patients in the hospital. So we manage infectious diseases, we manage the COVID patients in the hospital, and we're also responsible for things like some of the medications that they're given, and using some of the research therapeutics to help those patients. It's better than it was. A couple of weeks ago, it was extremely busy after the Thanksgiving holiday. We had a major surge upon a surge, and there were over 100 people in the hospital at Regent's Hospital, and we also managed some of the hospitals in the Valley, in Stillwater, and Western Wisconsin. This week, it's been better. I was on over the Christmas day and weekend, and we had about 40-something patients with COVID. So it's much better. We just have some people who've been there for a long time, and the people who come in and out.
Okay, what is it like? There's still a fear of even going to the hospital right now. Is that warranted? Are the beds at capacity like we're seeing in the news, or is this just what is it? What is that feeling like? The environment like now?
Well, right now, like I said, it's not too busy.
Okay.
But even when it's busy, we taking special precautions in the hospitals, all the hospitals, all the staff, everybody is wearing masks, everybody is wearing face shields. We are not really allowing any visitors to come in. We're restricting people and restricting people going into the rooms if they don't need to. So the hospital isn't that bad. It's we're taking care of patients from all over, and we're using a lot of precautions. If you need to come in, please come in.
Okay. Dr. Chomolo, same question for you. What is that like? Because you're also dealing with children. Are you seeing an influx of cases now after the Christmas holiday, or?
Yeah, so in my practice, my clinical practice, I'm in clinic every other week. And, at the beginning of the pandemic, we actually saw not too many people because we really were recommending if it was kind of an elective or just preventative care, which is a lot of pediatrics, that it be, delayed unless you're getting some of your recommended shots or immunizations. And so we've kind of had to get over that kind of psychological change of like, hey, it's okay to come back into clinic. And then we initially were sending most of our patients, to specific spots, specific clinics if they had COVID symptoms. And then we've now changed it so that if you have COVID symptoms, you can actually see your own pediatrician in clinic. You just have to, let us know ahead of time so we can take the right procedures and precautions and whatnot. But I would say, overall, it's still less than on the clinic side than, what I would usually see in a cough and cold season. Usually, I'd say a third of my day is seeing, kids with runny noses and coughs. And I think people are still a little hesitant, or they're getting appropriately screened and then getting sent to a drive-in testing site or sent to one of the, free testing sites that the state has stood up around the Twin Cities in the state. And so from that perspective, it's different. I still maybe one or two actual COVID tests in clinic a week, where I'm the one actually doing the swab and testing, but otherwise it's getting kind of sent and triaged other places. But parents are still have a lot of questions. I do a lot more of like video visits and telephone visits, talking about cold and cough symptoms or just other general health questions, and trying to kind of meet people where they're at that way. And I think for some families it's been really helpful. And then I think we talk a lot about COVID-19 as the disease and the impact on the community from the disease itself. But as a primary care doc, I'm seeing a lot more of the secondary effects. That is, I'm seeing a lot of kids with anxiety and depression, whether it's because they can't go to school and play sports or connect with friends or the same way they're doing, or they've lost someone in their family or their community, and are dealing, with that and how to navigate that, not knowing, there's a lot of, juniors last year, now seniors in high school who don't really like their whole world is kind of thrown upside down, right? They don't know what to expect of graduation or what college will look like or what the world will look like after this. And so I think I've spent a lot more time with families and kids dealing with some of those issues than I have in previous years.
Okay. So the kids are feeling the same effects that the adults are with this pandemic fatigue and the stress, and like everybody's just in flux at this point.
Absolutely. Absolutely.
And Dr. McKinney, we're getting lit up right now about this vaccine. So common thing, like they don't care about anything else at this very moment. But let's talk about this vaccine. For one part, there's, a new strain that's out of coronavirus that it's kind of this foreboding thing in the news in the UK, and now it's hit America. It's hit the States. Should we be more concerned about this new strain at this point as we're talking the vaccine, or is this just they have to still be just regular diligent? I mean, the news is kind of all over the place. Let's just be real.
Yeah, I mean, like with so many things we've been hearing about with COVID, I mean, there's still a lot more information yet to be learned. I would say the simple explanation is it seems like this new strain is more infectious, that is easier to get it, but it's not necessarily as deadly. So that, I don't know if that's a better or a worse scenario.
Okay.
I believe, at least based on what we know about this new strain right now, the presumption is that the vaccines that are becoming available should protect well against this new strain, as well as with what we've been dealing with so far. However, getting down to brass tacks, what we've been doing, wearing masks, trying to stay at home or distance in general, maintaining good hand hygiene, all still very, very important. And I can't emphasize that enough. And that will be just as true with this new strain as well.
Okay. And then in terms of the vaccine, because you are head of one of the trials right now in the state, what is that looking like? Are you getting more people coming in, maybe even after our last conversation?
Yeah, so as we talked about before, this trial is worldwide. It's kind of centered out of Oxford University in England, and they're trying to get 30,000 people enrolled. We're actually pretty close to that number. I think they're going to hit that enrollment marker either this week or next week, so we're almost there. There's been, I think, pretty good representation of a variety of non-white populations in there, and so that's been good. I mean, so I think we're at the point where we're starting to see some good data, and I'm expecting that they'll probably be applying for emergency youth authorization probably in the next 30 days, if not sooner. I think they would have probably been at the same point as these other vaccines that are already out there, but the trial got put on hold for about 7 weeks here in the U.S.
If we're in Minnesota, is it still open for someone in Minnesota to apply for the trial or to find out more about it?
It is very much, and right now more than ever. I mean, this was always the case, but the priority at this point is very much getting better representation of non-white communities in there. So if you're somebody who's Black or some from other BIPOC communities, now's the time to sign up. You got a few days left where you can probably get in, and so we want you. We're happy to have you. I'm happy to answer questions about it all day long.
What is let's see, who should I, the questions are coming in. Love you guys in the comments right now. They're coming, but I'm going to try to stay a little focused here before we get back into here. So thinking about, we have the trials going on, and last week we talked about Black folks not being wholly represented. Can one of you, maybe Dr. Akinseti, chime in on this conversation about how we need to show up for the vaccines and trials, and then maybe how we can be more diligent in protecting ourselves, because there's this misnomer that Black folks can't get coronavirus, right? We don't get corona, right? So let's talk about that.
Right. And that's really misinformation, because we actually are, brown and Black people are disproportionately affected by this virus, either directly through being sick or by the effects of somebody in their family being sick or dying. And the fact that people have lost their jobs because they can't work due to restrictions from the vaccine, from the virus, So I think it's extremely important for brown and Black people to be represented. In the data for the Moderna and Pfizer vaccines, they're about maybe 10% or so of Black people in the vaccine trials. We haven't seen any difference in allergies or side effects between the white and the Black and other ethnic groups or races. So in that sense, it's not targeted just towards African Americans. I've had questions about, well, what if they give you one and then they go and give somebody who is white another one? And that's not going to happen. They're giving everybody the same vaccines. But we do know that we need to be represented. Our communities are affected. We don't see any new side effects, but if there is one, we would like to see it before we start giving it to all the Black people, and we can prepare for it, if we will. Right now, I think it's the risk of COVID is a lot worse than any risk of the vaccine. I've had COVID myself, and I have to choose between COVID and the vaccine. I'll choose the vaccine in a heartbeat. The shows that the data is out there, very good data, and if you can be protected, then why don't you do it instead of risking your life, basically.
Okay, wow. And you said you've already had the coronavirus.
Absolutely.
What was that? I'm sorry for the slang, everyone. We sometimes make jokes of things to keep it together in our communities. What was that experience like for you personally, being a doctor and being treated for it?
Yeah, I think it was scary because that was mostly at the beginning. This was about the end of May and beginning of June, and we didn't really have all those medications out yet. We were still talking about hydroxychloroquine and things like that. And I had seen a lot of patients in the hospital get very sick, and a lot of people die. So it was scary, and we were still finding out things about the virus. The virus can affect any health, any organ in your body, basically. And so we didn't know where it was going to go. I was scared. I tried not to be scared for my family because we all got it. My children, my husband, we all got it. My husband has asthma, so he was coughing a lot. And I tried to be focused and optimistic for everybody. But it was scary. And after I got it, I kind of had a kind of peace in my mind that, okay, I've done it now, and let me go in and do what I need to do. But I always wore protective gear, always washed my hands, always wore masks after that.
So you were able to be at home for recovery. You weren't in the hospital on anything major at that point.
I had to be at home because I was infectious, basically, to everybody else. So I had to be at home. Yeah.
Okay. Oh, thank you. I'm just thinking about, there was a report earlier this week about a Black woman who was in the hospital. She was a doctor and was talking about treatment and believing that she had racist treatment for coronavirus, and that the doctors weren't hearing her voice. Do you think that's an issue in the general population, or is that more isolated?
I think it's isolated. I think it's absolutely isolated. We have I'm on the expert treatment panel for health partners, and we have criteria as to who we give medications and who we don't give medications. It doesn't matter where you are from. It doesn't matter your race. It doesn't matter your age. We'll give you if you need to get it. And we'll find, if we don't have it in our hospital, we try and find it from another hospital to get you treated. So it's not a concern.
Okay.
So I guess I have a little bit different.
So Dr. Shomolo? Yes.
Yeah. So I agree from a systems standpoint. There's a lot of good, systems that try to prevent it, but the fact is, medicine is a personal practice as well, and our personal practices are influenced by our own implicit biases or unconscious biases. And anyone growing up in the U.S., Black or white or Asian, has, indigenous, you name it, has breathed in the smog of, racism and anti-Blackness that we get taught in our media, and how we are represented in books, and how the news represents us. And so there was actually a really interesting, I think really on point thread by a physician who talked about this kind of cumulative effect of all the different little decisions that go into one's care when they enter the hospital, and how those, those decisions offer the opportunity for some of that implicit bias to show up. And I've seen this, to some extent myself, and heard it from family members and community members, and from my own patients when they tell me about their experiences in other parts of healthcare, where because you're a Black woman and you're scared, or maybe a little confused, that you are labeled as aggressive or intimidating, was actually a word used in the press release by Indiana University describing Dr. Susan Moore's behavior, and that was somehow a reason that she wouldn't have gotten listened to. And so I think whether it's the nursing staff, whether it's the aide that comes in to respond to the first time you press the light, whether it's the resident physician or attending physician, I think everyone carries some of these biases, and there's some doctors who are better at acknowledging that and working through it, and there's some that aren't. And so, even a well-intended system, I think we still see these different outcomes. And I think Dr. Moore's care, is a good point. I gave a lecture at Indiana University's pediatric grand rounds on structural racism back in June, and so I know that there's doctors there that understand and know this, and I got a lot of good questions and insight. But I think it's still just, if we don't constantly kind of check why we're having this gut reaction, why we are thinking that patient is aggressive, and let's go spend more time with that patient that looks more like us, that we communicate more easily with. Those are things that, as doctors, we and nurses and others always have to deal with. And I think that contributed to, what was a real unfortunate and, really frustrating, maddening, outcome for Dr. Susan Moore.
She documented it on Facebook throughout the whole time too. So here's another question for that before you guys, how do we advocate better for ourselves in that? Because there was a thing when she was just asking for pain medication, right? She was in pain. And that's something that we often hear, especially for Black women, to be in hospitals and request medication and being told they can't access something because they're treated like addicts. Or what can we do for ourselves without saying we Googled it?
Well, I'll just say that I'll just go back that I was talking mostly about COVID care. And in the past, just the question you just asked me, and the allocation of medications and how we treat COVID patients usually goes through infectious diseases doctors to give them medications and to give advice to the regular doctors, the hospitalists. So from our standpoint, we're using criteria. We're looking at patients. We're doing the best, at least at our facility. I can say that. But in terms of the other care, I absolutely agree. There is the healthcare disparities, even in the hospital. I agree with that. In terms of advocating for ourselves, one of the things I've told patients who have had issues in the hospital with staff, etc., is that they need to ask for the patient care advocate. They need to ask for the person who is in charge of experiences for the patients and tell them exactly everything that has happened. If they do not get anything back from that, there are ways in which they can actually send an email to Dr. Brian Rank, who is actually the one of the heads of Health Partners medical group in terms of the medical experiences, and he answers. I've had several where they have asked me to weigh in as to why this happened or why that happened. But yes, there are things that we could do. Don't give up. Don't say this is the way they treat you here. You need to advocate for yourself. If one way doesn't work, then go to the next way.
Okay.
I think those are good suggestions. And to be honest, Stephenetta, this is a question that I feel like has been coming up more and more this whole year with COVID and all these issues of health equity that have sort of come up after George Floyd. And I'm starting to think that we need to put together a playbook for people, like just a little folder of information. Hey, by the way, can you hand this to your doctors when you show up? And here's all the papers that have shown that Black people aren't taken seriously when they talk about pain and are statistically given less pain med less often than, other races and ethnicities. Black people aren't believed about their symptoms. I mean, you can name it, and it's been shown systematically in medical literature and science. And I don't want patients to be experts and have to explain that to doctors to say, look, here's the papers that have been written, published by your colleagues, peer reviewed. I'm not making this stuff up. I mean, honestly, I got referred a patient recently who was fired from their clinic, a Black man who had been through a lot of trauma in his life, been in foster care, been incarcerated. And so even though this guy was really interested in his healthcare and was interested in engaging me, he just was very outspoken, and I could see how he would come off as an aggressive, personality to maybe a white clinician. And so a lot of people had been blowing him off so much that they fired him from his last clinic. I mean, that's horrible that we get to that point where, we feel like we want to turn people away from care, even though they in fact may be interested in being engaged. And we're finding out more and more all of these adverse childhood events, ACEs, and this is probably more Dr. Chomolo's area of expertise than mine, really build upon each other to, make these types of interactions even harder for people. And the more they happen, the worse it's going to be.
And how do we come in and not be labeled the difficult one? Because I am the queen of, okay, I'm trying not to show research because I don't want to offend all of your years of training and medical practitioner. But at the same time, like, I know my body. And how do we do this? And I know we talked last time about maybe if you have your primary care physician who knows you. But right now I'm in the emergency room. What do I do? How do I not be labeled difficult? Or what do we do for that? Because that's also a fear of ours, is we want to advocate for ourselves, but we don't know how to do it without being like, have a little note check by our names for the next time we come to the doctor. Because that's what it feels like when they open it up.
Yeah. It's hard because, there's only so much you can do if someone isn't understood or recognized or addressed their own implicit bias. These are, whenever you're in the emergency room or in the hospital, it's a tough time. You're in pain, you're concerned, you're worried about what's going to happen next. And on top of that, now you have to like figure out how to communicate in a way that doesn't offend the sensitivities of the person who's supposed to, take care of you. But one of the things I talk to, parents and patients about is, having another family member, a community member with you that can also, be there and ask questions or, kind of help advocate for you. If there's anyone, in your community, whether you have, a nurse, a physician, a pharmacist, that you can kind of run things by, or, even someone in your faith community just to kind of, actually, talk through what you're feeling and experiencing in the moment, that and then kind of potentially advocate for you if needed. Those are the other ways you can try to prepare ahead of time. But I tend to agree with Dr. McKinney of like we need to figure out some way of having something that says we know that care can be biased based off of one's race and just how you perceive me to be, and so I want you to be able to check that, and when you're making your decisions, make sure that you've checked your bias in that process. It's really hard for us to ask our patients to ask that of us directly because of the power dynamics that happen in these. I as a patient myself, like I would worry if I had to ask my doctor, like, all right, you've come up with this plan. Are you sure there's nothing you're missing because I'm Black? Right.
Without saying that, that's the hardest part. Without saying that. And then we have someone who just chimed in on comments that really speaks to this part about advocating for ourselves, but what about family members like elderly or the more vulnerable patients who are in the hospital? They have COVID and no one can come see them. And so no one, no one can advocate on behalf of them in the same way. How do we empower them? She's asking here, let me just say, she thinks it's even harder for us to advocate for family members when you can't be at the hospital to ask questions and observe how they're being cared for. Her brother's in the hospital with COVID and video calls are not the same. And he's shown no improvement. And she just doesn't want to be a statistic anymore.
I think today, Dr. Akinseti's recommendation for getting a patient advocate there to really hear that person's experience and try to help facilitate the conversation with their treating providers is probably the thing we can do today. I mean, honestly, I would really advocate for having, patient advocates, social workers involved in every person's care, whether you're from low or high socioeconomic status, no matter what race or ethnicity you're from. Obviously, this is maybe over the top because health systems don't have the resources to do that right now. Maybe we need to get the Black doctor group to have, a 24-hour hotline, and I can talk to your doctor and the patient. I mean, I wish. I don't know if anybody's going to pay us to do that, but there are things like that I think we can do at a really more of a systematic level to address these things. Unfortunately, they're not ways in which we have been given resources to do it so far. I was reassured today, seeing, coming up from 2021, our billers and coders sent out an email in our medical group saying, hey, now you can talk about social determinants of health when you're coding your medical charts. Did people have access to housing or employment or all these other things? And great. Well, now we're starting to, collect data on that in a more systematic way, but, we haven't been for so long. And I think the more we can represent that these problems are there, which we already know, and it's already been proven. But, people got to hear the business case for it. They got to see the return on investment. But, somebody also asked in the comments, what's the track record for fair health treatment for people in hospital systems in Ramsey County? I'm going to tell you, it's the same as the rest of Minnesota and the same as the rest of the United States. People who are Black, for example, have lower access to good insurance. They have lower access to safe employment. They have lower access to safe housing. And all of those things lead to the same disparities in rates of chronic disease and illness that we see, throughout the United States. And the sooner that hospitals and insurers recognize the fact that prevention is going to be the most cost-saving thing that they can do, and providing these resources up front, or even all these resources outside of the health system that are going to impact people's health and care, I mean, that's where the money's at. That's actually going to save millions, billions of dollars. I just, when we're living in a world where people are thinking about, what's my profits or what's our return on investment next quarter, you're not going to see things like that quickly.
Wow.
Absolutely.
Okay. Yeah.
Yeah.
Dr. Zeke just
I
blew
know,
that
right?
up.
We're just like, there you go. Like, oh,
I was just going to give a quick, I actually unfortunately had a family member who had a stroke in the last couple of months and was in the hospital for several weeks, and I was in long-term care. And it's been really difficult because they don't allow visitors. Usually it's about 1 hour a day total, of any type of time that they can dedicate to someone holding a, iPad or, iPhone to help them communicate. And so I think one thing, kind of both to your question of what you can do to advocate but not to be seen as aggressive, as well as to help in these situations, is to try to designate, what we've done is, well, there's one member of our family that really runs point, on a certain day, and they're the ones that are talking. They have some medical background or understand some of those, finer, conversations, but that then allows there to be a little bit more clear communication, because if it's like your, brother and your aunt and your dad, who are all calling in, asking the same questions, our staff are stressed, right? They're human too. And, there's only so many times, as a doctor or as a nurse, you can kind of like go over the same stuff and deliver your best, right? And so if there's one person there that can help, you could also, then create a more longstanding relationship with the primary nurse or the primary doc, which can help again with clarity and with some of your asks and stuff. So those are some of the things in the meantime, while we get to Dr. Zeke's solution for our whole
community.
system. Yeah,
Right.
that you can do on an individual basis.
Well, Dr. McKinney will have a list, a playbook, and a 24-hour hotline. Let's go.
Don't give me too much homework.
Right. I have a question. Just thinking about this in terms of, we're talking about, advocating for Black communities, and, we have African and African American communities. Are you seeing a difference in how our different communities are showing up for treatment in the hospitals, or are they even showing up? Like, I'm Liberian, so, how are you seeing that show up for folks?
I think that there isn't that much distinction between African-born and African-American if people are going to treat you a certain way because of your race, basically. I would say that African-born people, some of us don't speak English, or don't speak English very well. So it makes it worse when you have to have an interpreter, or they just don't understand what you're saying. So you have that on top of being treated a certain way, or feeling that you're being treated a certain way, and then you're frustrated because people can understand what you're saying. So we in the healthcare system need to make sure that that's not an issue. We have right now interpreters that are on iPads, and we can put them close to patients and talk to patients one-on-one with the interpreter available as well. But I don't think it's available enough, honestly. I think we need to do more. There needs to be more resources put into this. I mean, on a personal note, I'll say that my dad actually died because of medical negligence, not in this country, but in Germany. And it was clear negligence from somebody who didn't appreciate the fact that because he was Black, we should do more with him. And so that, to me, has been something that has been burning inside of me, that we cannot let people treat us a certain way because of the way we look. We're the same as everybody else. On our sides, we need to we need to educate people. Things like this vaccine that we're talking about, we know that that's something that can protect us. It's just a small thing, but it also might decrease the morbidities, if you will. It might prevent us from going into the hospital, getting sick, and having to go through some of these issues that we're talking about. But it's not on us only. It is definitely in the healthcare system and in basically the makeup of the United States, unfortunately.
Right.
Can I go back to this point that Dr. Akinseti made, about, do more for this patient, and Dr. Shomolo brought that up too. We talk about these difficult patients, and then we kind of want to dismiss them, and then maybe spend more time with people who look like the medical system, or who look like the, whatever it is that the common society is expecting. But to be honest, I would say maybe that's the problem right there. Our approach is backwards. If we have a difficult or aggressive patient, that's the patient I think we need to spend more time with and more resources on, not less. or not, fire that patient from our clinic, but say, well, gee, what is it that we need to give this person to be able to interface with them more successfully and make sure that we're meeting their goals, not trying to make them meet our goals.
And you said fire from the clinic, and I thought you meant from a study. You are really saying just firing from, I can't come to this clinic anymore.
That's what the patient's doctor told me, and I was shocked. And that happens. I mean, I'm sure the folks on the call here can talk about it. If somebody, sometimes it's as simple as somebody misses, a few appointments in a row that are scheduled, and the clinic doesn't want to deal with that because obviously it's taking resources for somebody else who could have been there. But or if you're coming every time and you're yelling and screaming and kicking and punching people, I mean, that's a more dramatic case.
Right.
But it can be anywhere in between.
Okay, thank you. And let's come back to this vaccine, right? So Dr. Akinseti gave us a clear bonus for why we should do this, a very positive reinforcement. The idea, if you take this, you don't have to go to the hospital, hopefully, and have to deal with the drama of not being heard or seen, even though those things need to be addressed as well. How else can we sell this vaccine to folks in a matter of speaking, for when it does become available, for people who are concerned, still about this idea that I don't want this, I don't know what this is, they haven't tested it, even though it's in trials now and it's being tested.
Yeah. I mean, I can talk about the vaccines that are available, the Moderna and the Pfizer. These are different a little bit from the AstraZeneca vaccine, which Dr. McKinney is heading over at Health Partners. But in general, most people are used to vaccines having either a weakened virus or parts of the virus, or something to stimulate your immune system. The mRNA vaccines, which are the Pfizer and the Moderna vaccines, basically do not have the whole virus in them at all. It just has a small little piece of the virus, which is basically a code, something that tells our cells to produce the little proteins from the virus, and then our body recognizes them. And then if we get infected again in the future, our body is already primed to recognize them. The mRNA doesn't get into our cells, into our nucleus. It doesn't get into our DNA. It disintegrates totally. And so does the lipids. There's a little bubble that it comes in to get into your system, to enable it to get into your system, made out of some fats. Basically, that disintegrates as well. And the reason why it was so fast is that they've been working on it for over 10 years already. They tried it with other vaccines, influenza, Zika, some other vaccines, rabies. The problem was that the immune system would kill off this little messenger RNA, we call it, that gives us a code to produce this, gives our cells a code to produce the proteins from the vaccine. So we'll recognize it later. But when they were able to put it into a little bubble, as I call it, because it's just a fatty coating, they were able to evade the immune system. So the immune system doesn't recognize it before you get into the muscle cells. But once it gets in there and it tells our cells, produce proteins from this SARS-CoV-2 virus, and then spread it all around, and then our body recognizes it. It's not a whole virus, it's not infectious. Right. And that's why it was done so quickly, because all they needed was that small part of the virus, and the whole part of the virus has already been sequenced from January. All they needed was that little part, and they were able to produce it very fast.
Okay, so there were already systems in place for it to go. So it wasn't just this magical thing that is going to have people looking like zombies, because those were the memes all over the
exactly
over social
exactly
media.
And I would say,
Dr. Chomolo and Dr. McKinney who've had the vaccine. Have you had it as well, Dr. Akinseti?
Yes, I have. I got it last week. Yeah.
So 3 right here.
So I actually don't know if I got the vaccine yet or not, because I entered the trial, and so I have a 2 in 3 chance of being one of the participants that got the vaccine, but I won't be what's called unblinded until I get an offer from my health system to get the actual vaccine. But I think, what Dr. Akinseti is getting there is, and what to answer kind of your question is, what do we need to say is, I think we just need to have a lot of conversations and really be welcoming to questions and concerns and kind of share our own experience. And so, you know what, I did a recent Twitter thread, like a long 35 tweet thread about, you know, how I have had, you know, hesitancy around the COVID vaccine earlier this year. You know, I was also concerned about how fast it was going. I was concerned about some of the newer technology because that was something we didn't learn in medical school when I went through medical school about it. And so, you know, I talked about the steps I took and how I had to educate myself first and, you know, read the basic science, listen to some of the experts that I trusted, and then, you know, talk to local experts like Dr. Zeke in the community who I trusted as well. And that, you know, helped me arrive at a place where I wholeheartedly agree that you know, the risk of COVID is so much greater than the risk of the vaccine. And one of the things I talk about when we talk about speed is, you know, like Dr. Akinsetti said, the technology is different. So they didn't need to like grow cells in cultures, which like older style vaccines, you have to grow a lot of cells in cultures, and that takes months before you can find your candidate. Second is the money. Like there's been tons of money spent on vaccine development, which usually is not a big money maker. And so what that does is, you know, you've heard of these different phases, right? Phase 1, phase 2, phase 3 trials. Well, you know, usually companies will wait until they know for sure that something's completed one phase before investing in the next phase for vaccine development. But this time they started getting phase 2 ready while, you know, they're waiting and kind of anticipating that phase 1 would be good. And they got phase 3 ready while they're anticipating phase 2 would be good, so that things can move along faster, you know, because the government kind of helps subsidize it so that there was less financial risk to companies to do that. And this has been done with other drugs too, like cancer drugs have used this approach before because there's a lot of potential benefit if you get those type of drugs to market fast. And so the money is a big one. And I'll share a quick analogy that I found on Twitter that I really like. It's like if you have all your aunties come over and clean your house, you know, your house is going to be clean faster. You're still going to think it's a pretty good job done, right? And that's essentially what money does. You know, all this attention gets a bunch of scientists doing it, and they're able to do it faster than if it's just a couple scientists that are working on it at a time. And then last is we're in a pandemic, right? Which means to actually know if the shot works, you have to be exposed to the virus. And so if this was like a rare, you know, coronavirus like the SARS or MERS, which happened earlier, but kind of happened and then went away fast, it's a lot harder to develop a vaccine if there's not an actual, you know, infection going on, right? Because you don't know if it works, right? But we're in a pandemic, so that means once we get a shot developed, we can test it and find out if it works really fast. And all those things really help.
Yeah, I want to.
Yes.
Oh, I was just gonna say all those things really helped me, you know, feel very, you know, comfortable that the right steps are taken. You know, I looked through the data from the release of the FDA, you know, decision, and you know, looking through the data also helped me, you know, feel really comfortable with the speed and that all the appropriate steps have been taken.
Mm-hmm.
I just want to double down on what Dr. Chomlo was saying. I mean, basically, yeah, the two big things about why should we feel safe about this science if it's happened so fast is one, we've never had this much money thrown at vaccine development in the history of time. Number two, it's also pretty much never done in diseases that are this common, so you can see if it works really fast. So this is a very unique situation in that way. And so the science is still the same. We've just had the opportunity to have a lot of resources and availability to see if it works. You know, the people in the comments are talking about, you know, the side effects that people are getting from vaccines. So I've actually been vaccinated, not as part of the trial because I'm working on the trial, so I actually couldn't get that one. And honestly, yeah, for the most part, my arm was sore. The next day I was a little tired. Some people have had more significant symptoms, you know, mostly like a little fever, chills, maybe headache, maybe feeling tired. That's the common stuff. And that's actually really consistent with what has been shown in the phase 1, 2, and even some of the phase 3 data for these other vaccines that have been out. So I'd say, you know, you take all that in the context of what Dr. Akinsetti which is, you know, we know what COVID will do to people, and it's not good. I think I would take the risk of getting the vaccine and having, you know, some type of minor illness in comparison. And the good news is if you get those side effects, that tells you that it's working, that your body is actually generating an immune response in the way it's supposed to. So I am reassured by doing this research. In fact, one of the reasons why I wanted to be part of this was so I could speak to Black people and to communities of color and say, look, I'm one of the people in charge of this here. If something was going wrong, I would be the first person out there blowing the whistle, making a big deal about it, because I am not going to put my name on something that isn't going to be safe, and I'm not going to, participate in research that isn't being done to the highest scientific standards and rigor. And so, the reason, for example, I said that this trial was on hold for 7 weeks was because somebody did get sick in England. And anytime somebody gets really, really sick or dies in a trial like this, everything comes to a screeching halt immediately. Now, in England, they looked at this in like 3 or 4 or 5 days and got started up again. For some political reason that's beyond me, it took 7 weeks here, and I can't get into all that. But the point is, people should be reassured by things like that, that these types of studies are being done very, very safely.
Okay. I'm also reading here about, I know we need the vaccine. Folks are still talking, about alternative treatments. Are there things, supplements that we should be taking at home to help prevent? If it's not cure, but prevent, or should we be doubling up on the zinc and the vitamin D3 and other new supplements to help us be less susceptible to coronavirus or COVID?
So the person in the comments suggested that those treatments are being dismissed, but to be honest, there's actually quite a bit of evidence suggesting that vitamin D deficiency does contribute significantly to COVID-19 infection and severity. And in general, I mean, zinc and vitamin D are actually really great supplements to take for prevention of infections. But I actually might punt to Dr. Akinsetti and let her talk about that, given it's more of her area of expertise.
Yeah, I mean, I think those would, like Dr. McKinney was saying, will help us in terms of our own immunity, helps us be more healthy, and helps us to have a more robust immune system. Like you said, there are some patients who have had, we think vitamin D deficiency can make COVID a little bit worse. But regardless, there are so many people who are vitamin D deficient, especially in Minnesota, where you hardly have any sunshine for several months. But basically, these things can help your own system to get better, like in any viral infection. They haven't had any trials like we're talking about that will tell you, you look at a group that has taken it and a group that hasn't taken it. They haven't really been any big trials like that will prove it definitely. But we do know that some of these things anecdotally work. Now, in terms of the COVID virus itself, I don't think that helps at this point. We haven't seen any data that it does. Most people will get rid of COVID by itself, by ourselves. We don't need treatment. We don't need any medications. But for the people who are really sick, who are short of breath, who have severe cough, fever, and they need oxygen to breathe, those people definitely need to be on the medications that we know work and not the medications that we think could work. But people at home, anything that can make us feel better is just fine. He's not going to make the COVID any worse.
Okay. Yeah, I think it's good to kind of clarify that these treatments can help with symptoms, but they don't necessarily help, prevent COVID. And I think the thing that I've been pointing, because I've seen over and over in my WhatsApp channels, the kind of video of someone standing in front of a pot that's boiling and they're kind of whiffing in, breathing in the fumes. And my dad tells me that is what his mom showed him back when he was growing up in Cameroon. That's like the way to go. And I was like, yeah, that's okay to help you feel better when you're sick, but you're still like infectious. You still have to, be careful around others because you can still spread it, even if it's helping you feel better. It's not a cure. And so, none of these treatments, I think should be in place of things like masking, like distancing, washing your hands. I think this needs to be all used together, is kind of the key point there.
Mm. Oh, Dr. Chomolo, also, working with kids and youth, I know there's a question about new strain appearing in Colorado, and what are the chances that high school seniors will have a traditional graduation ceremony? I know you can't speak to that specifically, but there are kids right now like, I want to graduate.
Yeah, so I think the connection that can be made is to vaccination and graduations and celebrations in the summer. I'm also serving on the Minnesota COVID vaccine allocation advisory group, and so I'm kind of tracking how we're doing with that as well. And so what I've been telling my patients and families is that I think it's probably like 6 to 9 months before we have a widely available vaccine for kids. At this point, and that's kind of like my optimistic timeline. And so, I think that unfortunately means that there probably isn't going to be your kind of normal graduations. We might get to a point where you could do something outside in a little bit smaller, group, but I think the risk is still going to be pretty high even when we get to the spring. I have trying to tell people to kind of mentally prepare to, like, summer is when I think we'll have a widely available vaccine for kind of everyone, and then at that point it's going to be taking our people in your community getting vaccinated. There's this herd immunity, or like I like the term community immunity better, and you need like 60-70% is what we estimate of people to either have had it or be vaccinated against it to really have that protective effect where you can kind of get back to a place with less restrictions. And so I think we have some work cut out from us to get 60 to 70% of our community on board with vaccination.
Well, and I know earlier today there were reports from CNN about Dr. Fauci saying that we were below, the country was below like a target number for the number of vaccines right now in terms of who's actually gotten what's available. And so what percentage what percentage we need to get to in order for us to have this community herd or community
immunity? Yeah,
immunity.
around 60 to 70% are the numbers that I've seen.
Wow. Okay.
And that includes people who've had it and survived, but it's still a pretty high bar, and we're having issues with getting the vaccine out. Some of it's consistent shipments from the federal government, and so it's really hard to plan, particularly because these shots are a 2-shot series, right? You get your first shot, and then you're supposed to get your next shot within 3 or 4 weeks, and so you can't give everyone the first shot if you don't know that for sure they're going to get the second shot within that 3 or 4 week window when it's been shown to build the immunity to the response we want. So yeah, I think there's only been around 2 or 3 million folks that have actually gotten the shot in the U.S. when at one point there was talk of 20 million.
20 million they wanted by the end of the year, and now we're at 2 to 3 million. And so then what does that allocation then look like for us, say in June, when you're saying maybe in 6 months? Like, how do we know how that we can get it? Because I know there's a whole, we don't know. We're reading the reports and say there's a whole mess when people are trying to get the shots, and people cutting lines and saying they're in a different whatever. What does that look like for us? Because if the doctors are doing it, the nurses are doing it, regular folks are gonna be like, well, I need that.
I mean, honestly, I hope that's the problem that we have, that there's so much demand that, we're having to figure that out. And if that's the case, the couple points that should be known is that the way it's currently structured and written is that it's going to be free of charge, which means you shouldn't get a bill for the vaccine. You shouldn't get a bill for a nurse, or a doctor giving you the vaccine. And it's likely going to be a combination. You might be able to get it through your regular doctor. You might be able to get it through like a CVS or, Target Pharmacy, or I believe the state is going to plan on setting up, sites for vaccination like they had, testing sites.
For the COVID
Yep. Mm-hmm. And so and it's going to depend too on the types of vaccines. So like the trial that Dr. McKinney is running, that vaccine doesn't require the ultra cold storage, like those -70 freezers that some of the mRNA shots do, and that will affect the availability of it as well. And so I think there's probably going to be and I'd like to hear Dr. Akinsede's take. There's probably going to be at least 3 or 4 shots, by the summer that people can get. And so that's going to be another wrinkle, because we'll have to kind of talk about the slight differences between them and all. But I think that's the way that we get the numbers up to that 60 or 70%.
Absolutely. I was just going to add that the most infectious virus that we know of is measles. And measles, if you get like 90% herd immunity, then you can cut it off. And when you see outbreaks, it's because it's gone below that. SARS-CoV-2, which causes COVID-19, is not as infectious as measles. So something that is less than that, which we've talked about now, is that 70%, 75, 80%, somewhere there, I think will cut the numbers of people who are getting infected in this country and I guess all over the world. And then in terms of the vaccines, yes, AstraZeneca is different and Johnson & Johnson is the fourth one. We're hoping that if all of them, and it's a very good chance that they will get approved very, very soon, then we might have 4 vaccines circulating, and maybe we'll be able to get more people infected in the United States and in other countries where they can't afford cold freezers.
Okay. How do we determine then what vaccine we get? Because it's not like we're coming and ordering, I want this one. Is it talking to our primary care physician, or is it just what's available at that moment? You're just going to figure out life.
I think it's what's available.
Okay.
You get what is available. The advantage of the Johnson & Johnson one, though, is that it's one shot and not 2 like the others. Yeah. So that might help, in some cases. But it's whatever is available. All of them seem to be very effective.
Okay. Going to just ask our audience, if you all have any other questions for our 3 amazing doctors, please drop them in before we close out. We have a couple more minutes, and I would love to get from you before we go, the conversation or the thing that we should be talking about or paying attention to when we leave you guys today. So we turn our computers off. What's the thing that we should be focused on in terms of this pandemic, and not just washing our hands, but in terms of care, in terms of even maybe our mental state, like what's the thing that you wish we were doing or focusing on right now in this conversation?
Figuring out all the reasons that people are hesitant about vaccines generally and about COVID vaccination specifically. Some of them are racially and culturally oriented, but some of them are more broad. I mean, we see, even white people don't want to get vaccines. And we as medical professionals and you as a media professional have to bring those messages together and get that word out. I mean, vaccines actually work. We have years and tons of people who have been vaccinated for tons of different diseases, and they work great. And I think by far the benefits very much outweigh the risks. Okay.
Thank you.
I think that people should, from this conversation, should, maybe educate themselves more if they feel that they have more questions, and should be able to spread the word to other people and say, this vaccine doesn't seem as scary as we thought it was. This is what happened. This is why this happened. Look it up, etc. And then maybe people will feel more comfortable receiving the vaccine when it's their turn.
Okay. Yeah, and I just add to my colleagues' comments, to not be afraid to ask questions. I think what we really need is honest conversation, and it might take a couple conversations for you to get there, and that's okay. Just don't give up on it. Don't close your mind off, too soon to the potential benefit, because it's not just about us individuals. Even it really is about our community. 1 in 800 Black Americans have died from COVID-19, which is crazy. So keep having the conversation.
Okay. Well, thank you. We will definitely drop some links in here on where we can find you, some resources for the community. I will also, once we log off, actually drop a link to the clinical study. If for someone to be screened, if they want to still participate, to learn more and to ask questions. And again, everyone here is, these doctors have given us their time, their valuable time. So if you have questions or comments, please drop them in and we will try to get them answered, or at least share some resources to point you into the right direction. But we are grateful again for your time, and thank you so much, Dr. Zeke McKinney, Dr. Bosola Akinseti, and Dr. Nathan Chomolo. I'm going to look, you see my name? I should get your names right. Dr. Nate Chomolo, thank you so much. Let me do some of our general housekeeping, and then if there's any last words, then we can get that going. As you all know, thank you again. The MSR Forefront is sponsored by Ramsey County Research, where we must slow the spread of COVID-19 and protect our communities. Stay vigilant during this time. Wash your hands often. Wear a face mask and stay 6 feet away from other people. And also sponsored by the Minneapolis Foundation Funds for Safe Communities. MSR Forefront is proud to be on the front lines with the Minneapolis Foundation to support efforts to prevent violence, address systemic inequities, and heal individuals and families. MSR, the Minneapolis Foundation, and the citizens of the Twin Cities, let's find solutions together. I got my mouthfuls in there. Yes.
Did a good job.
Well, thank you so much. I appreciate you. And we will reach back out, for other questions. We hope to have you back on in other capacities. And again, your knowledge is just immeasurable and so invaluable for our community. So thank you so much.
Thank you.
All right.
Happy to be here. Thanks for having us.
Thank you for tuning
Bye.
in to the MSR Forefront.
Thank you.